Thank you for that very kind introduction. I'm really excited to be presenting as part of this session. The title of my talk is Studying the Implementation of Stigma Reduction Interventions in Low Middle Income Countries. I'm really thankful to the Heart of Stigma team, including Lucy Stackpole-Moore, and the chairs of this session, Dr. Sanders and Dr. Pozniak, for the opportunity to speak to you today. So similar to the other sessions, I don't have a lot of time to talk to you today, but I want to introduce implementation research a little bit and really talk about the sort of traditional research pipeline that exists within stigma research. And then I'll really focus on where have we used implementation research and stigma in the context of stigma research, and what the potential roles of implementation research in stigma could be, and then some thoughts on moving forward. So when we conceptualize the traditional research pathway, we really think of research moving from pre-interventional work around hypothesizing whether a program could work, then the sort of efficacy and effectiveness studies where a program is assessed whether it does work, and then we really move into this real-world dynamic or implementation research, which is really how do we study how to make a program work better. And within implementation research, there are even 4 stages, one framework used, including the exploration phase, the preparation phase, the implementation, and then ultimately the sustainment phase. But what I'll note for stigma research is that a lot of the work I think we've come to understand is pre-interventional, is understanding the role of stigma in worsening outcomes. There has definitely been, and I'll talk a little bit about the efficacy and effectiveness studies, and we and others have led systematic reviews assessing what those are. But really, we now want to understand how do we make stigma research and stigma mitigation programs work better? And so how do we better integrate implementation research to the field of stigma and to really optimize the sort of stigma interventions that we've heard about from other speakers, and both in the session and across the conference? Now, there are absolutely EBIs or evidence-based interventions or ESTs in terms of empirically supported treatment that is really focused on stigma. However, we really haven't done as much of the work in between. So we have some understanding of whether those interventions can improve health outcomes at the individual, at the population level, people's satisfaction with services. There's even been some research in terms of the efficiency and safety and effectiveness of these programs, whether it's patient-centered. But really, it's the stuff in between. It's how do you translate this idea into a strategy? How do you pull it off? And today we're really talking about at the clinic level, how do you make these interventions work at the clinic level? And how are you evaluating that at the clinic level? Like, how are you specifically making it happen? And how are you specifically evaluating it so that you have some understanding of the relationship that exists between those interventions through to implementation, and then ultimately to the service and health outcomes within this research pathway. Given the very limited time today, I'm going to briefly talk about how we wanted to systematically assess how implementation research has been integrated into stigma interventions across low middle income countries, and then I'll talk a little bit about the reporting of those interventions. So the methods used for this study were a very traditional systematic review registered in Prospera with a number of different databases. Because of the sort of breadth of stigma interventions, we had to use these different databases. We focused on stigma implementation outcomes, and the inclusion criteria were the study had to include empiric data. It had to include an evaluation of a stigma reduction intervention. It had to be based in a low middle income country, and it needed to report at least one implementation outcome of the ones that I just described to you. So just in terms of presenting the PRISMA diagram, we started out with over 9,000 citations that were deduplicated and reviewed, and we reviewed over 250 articles and included 35 studies with 29 different interventions described. So what did we see in terms of the results? Well, I think one thing is to say that out of the 35 studies, There was none that used a theoretical framework for implementation research. There were none that used established measures of implementation outcomes, which I think was a challenge for us. Nearly 60% were focused on qualitative methods, which obviously is fundamentally important, but less so in terms of quantitative outcomes. Most of them focused on acceptability. Very few looked at any sort of cost measures. When we look at the 29 interventions, almost 2/3 were based across sub-Saharan Africa. 70% focused on HIV stigma only, so as compared to the other intersectional stigmas that we've talked about today, and really I think is increasingly the focus in terms of stigma affecting gay men and gender identities, etc. More than 80% really just focused at the community level stigma. Almost all of them, the intervention was some form of IEC in terms of information and education. And only 60% reported a tidier score, which is really a measure of implementation. So what does that tell us really as of right now? What is the state of stigma-related implementation research? Well, one, there's really still not that many stigma mitigation studies that are out there where we've included implementation research. And the vast majority of them focus on HIV stigma. The vast majority take place in countries across sub-Saharan Africa, and almost all were pilot interventions. There really were no scaled interventions there. The interventions that had looked at scale, and there was a couple, really just focused on mass media or targeted structural changes, and there was really no individual level support or service delivery in terms of like clinic level interventions. We saw no study that incorporated a theoretical framework, which I think people really appreciate as being fundamentally important, evaluated specific strategies or used validated measures of implementation outcomes, which I think is increasingly the norm in the context of, sort of interventional research. The vast majority focused on acceptability and feasibility, but very few really looked at adoption, appropriateness, cost, fidelity, penetration, sustainability. And the intervention descriptions were really sparse. So it didn't have the detail you would need in order to be able to replicate that intervention or to adopt it in an actual clinical practice. So with that very short presentation, I'd like to summarize some key themes. I think a key theme that really emerged from us is that we can use implementation science methods to better specify the interventions and to really evaluate the impact of stigma mitigation programs. We think there are these incredible opportunities for engagement between stigma researchers and implementation researchers. We think there are great opportunities to use theoretical frameworks and validated measures and study designs like hybrid effectiveness implementation study designs to give some insights into optimal implementation strategies. And we think that doing this, what we've seen from other strategies and other interventions outside of stigma, is that it really promotes real world implementation because we have that evidence around cost and sustainability. So with that, I really want to thank a number of different people, including the people who participate in these studies. There really is very little personal benefits, especially when we are talking about people living with HIV, gay men, sex workers, that really are at significant risks in many of the settings in which they work. I've included here the full citation of this work, and it was really led by Chris Kemp and Brooke Jarrett, included myself, and want to thank the NIH for the funding support of this work. Thank you very much again for the opportunity to speak, and I look forward to the Q&A.